All right, so good morning. First of all, let me thank Dr. Natasha and the scientific committee for having me here and allowing me to talk on this topic. So I'll be speaking in a nutshell about 10 clinical pearls in infectious uveitis. Now the first pearl that we have to remember and the first rule of infectious retinitis is that every retinitis is infectious unless proven otherwise. So whenever you see a retinitis, the first thing you have to think of is you are dealing with some infection. Whatever might be the underlying etiology is a different issue altogether. But the rule is that it is infectious unless and until you are able to rule it otherwise. One of the most common non-infectious causes of retinitis is Behçet's. Very rarely sarcoidosis can very rarely present with retinitis, though usually it is choroidal. So otherwise every retinitis, golden rule, it is supposed to be infectious unless you can probably rule out all causes of infections otherwise. Now, the second point in retinitis is a lot of times people do get confused whether you're dealing with a retinal involvement or a choroidal or a scleritis, and how can you identify that? So, a very important investigation can be an FFA, a fluorescein angiogram, whenever you are in doubt, can help you in identifying whether you are dealing with a retinitis or a choroidal lesion. And the things to look for are, number one, the intensity of early hypo, and then the pattern of early hyperfluorescence. So two things, intensity and pattern. So if you have got intensity of early hypofluorescence is maximum in retinitis, and I will show you the example, followed by choroiditis, and the pattern of early hyperfluorescence, that's very important. So retinitis will have a perilesional hyperfluorescence, whereas the choroidal involvement will have an intralesional hyperfluorescence. So let me show you how. So this was a patient of retinitis, and if you look at the initial hypo, the initial hypo is maximum in retinitis as compared to choroiditis. And now look at the pattern of early hyperfluorescence. The pattern of early hyperfluorescence, look at it, it is perilesional. Whereas over here you start seeing a diffuse intralesional hyperfluorescence. So whenever you see a perilesional hyperfluorescence, you can rest assured that you are probably dealing with a retinitis rather than a choroidal involvement. Scleritis is not that difficult to diagnose in terms of the fact that you will get pinpoint leakages and a T sign on your ultrasound B scan. But the point where a lot of people get confused is whether it's a choroiditis or a retinitis, and these clues can help you in identifying both of them. Now, clinical clues to some very common disorders which we have started seeing more and more in our clinics, and which should not be missed because these are obvious clinical diagnosis where you need to probably just order a lab investigation to confirm what you're dealing with. So, a placoid chororetinitis with more intense infiltration at edges. This is what you need to remember. You see a placoid chororetinitis lesion and you see more intense infiltration over here at the edges. Get an OCT through that and you see this photoreceptor damage and RP nodularity. Put both of these together, you are probably dealing with ocular syphilis. So that's one clue to diagnose ocular syphilis. The other patterns to diagnose syphilis are if you see these multiple miliary lesions. We are not talking of vitreous opacities here. We are talking of retinal multiple miliary lesions. So you see them and you do an OCT and you see that it's got a full thickness retinitis. So miliary lesions with full thickness retinitis, or a ground glass retinitis like you see this diffuse hazy sort of a retinitis with a central clearing sometimes. Now you see these patterns, these again are clues to the presence of an underlying ocular syphilis. And remember, ideally all patients of uveitis who present to you, at least that's what we do, should be tested for syphilis. So we get all of our patients tested for TPHA, which is a treponemal test which stays positive, as compared to VDRL, which has got only 70% sensitivity. So we have actually made this mistake earlier. There was one patient whom we only got tested for VDRL, came negative. We never even entertained the diagnosis of syphilis and started this patient on steroids. When the patient worsened, that's when our the bells rang, and we got the patient now tested for TPHA, and we found TPHA to be positive. Subsequently, we have now found that nearly 20% of patients can be VDRL negative but TPHA positive. So the rule is get your patients tested for the treponemal test like TPHA first to diagnose syphilis. VDRL titers can be used to monitor the response to treatment. So a 4-fold reduction in your VDRL titers along with the resolution of your clinical picture together constitutes the definition of a cure in cases of ocular syphilis. So first thing, remember the clinical patterns. If you see this placoid chororetinitis and RP nodularity on OCT, if you see these multiple miliary lesions or a ground glass retinitis, these are clues to syphilis. Get your patient tested for TPHA. If that comes positive, then you are on the right track. And the good part about syphilis is the one disease which we can completely cure. So patients with poor visual acuity end up having a miraculous recovery to as much as 20/20 in a lot of these cases. Moving on to identifying toxoplasma. Toxoplasmosis is usually the most common cause of a unifocal retinitis lesion. So if you see a single unifocal retinitis lesion, in most cases, you are dealing with a toxoplasmosis. Get an OCT through that, you will see a chororetinal involvement. The other point to remember is that in cases of reactivation, a reactivation of toxoplasma usually always occurs from the edge of a scar. So remember that if you see a patient with a pigmented lesion over here like what you see over here and you see a retinitis lesion adjacent to it, rest assured that you are really on the right track. You are probably dealing with an ocular toxoplasmosis and nothing else. So reactivation from the edge of scar, unifocal retinitis lesion, most commonly toxoplasma. The other thing to remember is what all can also happen. So a lot of times toxoplasma can cause an intense vitritis, what we used to call the headlight in fog sort of an appearance. But remember, intense vitritis is predominantly seen in two other diseases or two other conditions. One is ARN and other is pars planitis. But if you see through that vitritis and you can see a central lesion somewhere through that retinitis, through the vitritis, you are dealing with toxoplasma. If through that hazy vitritis you are able to see some lesion in the periphery, around the ore or in the margins, then probably that's an ARN. So the two most common causes of a dense vitritis otherwise are, in terms of ocular infections or uveitis, are toxoplasma and ARN. The other causes sometimes can be an endogenous endophthalmitis, which you need to rule out again. But otherwise, if you can see through that fog a central retinitis lesion, central yellowish sort of a lesion, toxoplasma. If you see that central yellowish sort of a lesion in the periphery, probably ARN. Now also remember, occasionally toxoplasma can also mimic with an ARN-like picture. Actually, it's called an atypical toxoplasmosis is what most of people label it, but it's easy to diagnose these also if you look at them carefully. Now this was a patient actually who was treated as a ARN, was given intravitreal ganciclovir before the patient came to us. But the point is, if you look carefully, you will see this triangular sort of a retinitis, but more importantly, if you look carefully, what you will also see is this pigmented scar adjacent to it. So just remember what I told you 5 minutes back. Toxoplasma usually gets reactivated from the edge of a scar. So this actually was not a case of a viral acute retinal necrosis, but this was an atypical toxoplasmosis in this patient. So if you see a scar and then you see a retinitis lesion adjacent to it, that's a very important clinical pearl in identifying toxoplasma. Moving on to another lesion which can occasionally present with a unifocal lesion, but if you look at it, you will be able to appreciate the fact that it is probably seeding into the vitreous. This is how usually Candida endophthalmitis presents with. So if you see a patient who now probably also gives you history of some intervention done earlier, like what Dr. Partho said, that patient gets a history of a tooth extraction. This was actually a lady who had undergone a hysteroscopy 3 weeks back before she presented to us. And you can see this lesion, you can see this multiple string of pearls or bead sort of an appearance in the periphery, multiple few small vitreous exudates, but more importantly the central unifocal lesion. And if you do an OCT through this, you can see something erupting through the OCT. So you see this large, this is called a rain cloud sign, which is seen on OCT, which is pretty characteristic of Candida. So you see this lesion which is protruding through the vitreous, and beneath that you cannot see the underlying retinal layers. That is the thing which you need to remember. There are times when people have erroneously labeled just some vitreous exudates as a rain cloud. That's not what rain cloud is. Rain cloud is a lesion which is now from the choroid. That's how endogenous endoph spreads, like from the choroid to the retina to the vitreous, and you cannot see the underlying retinal or choroidal structures underneath that. So that's a rain cloud sign which you can see over here. Unlike that, aspergillus usually will have a deep retinal with horizontal enlargement. So Candida may have a unifocal single solitary lesions in a lot of cases, sometimes even 2 lesions, but they will not be horizontally widespread. And you can occasionally have a hemorrhagic vasculitis along with it. So if you diffuse widespread sort of a lesion, which is sub-RPE and subretinal space is involved, that usually is how aspergillus endophthalmitis presents with. Now the other clue, other disease which you should learn to identify, which can be a big masquerade, is an intraocular lymphoma. So you see a patient, usually elderly patients who may come to you with significant vitritis, multiple vitreous clumps, that in itself should set the alarm bells ringing. Is it something else rather than a typical uveitis? So dense vitritis or multiple vitreous clumps, clue number 1. Multiple yellowish sub-RP lesions, if possible, sometimes even an optic nerve infiltration, again should alert you to the fact that probably you are dealing with an intraocular lymphoma. Also, sometimes the history can be very characteristic. You may have a history where the patient has been given steroids, the lesions resolve, and then sometimes later the vitritis comes back again the moment steroids are discontinued. So if you are seeing recurrent inflammation in an elderly patient with vitreous clumps, think of a possibility of an intraocular lymphoma. Also, these clinical lesions need to be appreciated and understood. So if you see these creamy yellowish lesions with deep infiltrate, some pigmentary changes over here, what you call a leopard spot. And if you do an OCT, you see this RP nodulated and this sub-RPE infiltration. So this sub-RP infiltration, if you see that, that is also very characteristic of an intraocular lymphoma. So you see a patient who has got this well-defined subretinal lesion, which is called a leopard spot, and you see this sub-RP infiltrates. Probably you are dealing with an intraocular lymphoma, so this should be something you should be aware of, and we should keep at the back of our mind that this probably can be an underlying lymphoma and not something else. Now moving on from infection, some non-infectious entities which have been labeled as infective. So this is what you should be aware of. Do not let masquerades fool you, or be aware of the masquerades. So this was a patient who was labeled as a retinitis and referred to us. Before that, somebody had actually started this patient on steroids, but look carefully, you see this yellowish lesion, but through that you see these two small areas of lucency. So if you see a yellowish lesion and through that you see these two small lucent areas, that probably is a CSR, and what you are seeing as this yellowish thing is nothing else but a subretinal fibrin. The best investigation to be done is probably an FFA, and a fluorescein will show you multiple leaks. But an OCT in itself can help you. So you get an OCT, then you see this PD, and you see this area of lucency through that area of fibrin. So remember, sometimes masquerades can mimic, and you should not just go on a one-track mind. You should keep your mind open to differential diagnosis. And I'll come to my last pearl, which is again a masquerade. Remember, a hypopion, again in patients who are getting treated for tuberculosis, may not necessarily mean a reactivation of the infection. Ask or look for a careful drug history. If your patient is taking rifabutin, then anterior uveitis is known to be a drug dose-dependent effect of rifabutin at a dosage over 300 milligrams. So it may even present with a unilateral or occasionally a bilateral hypopion, and this hypopion will resolve the moment you discontinue rifabutin. So keep in mind the fact that you may be dealing with the other entities also. Be aware of masquerades and look for these clinical clues or pearls which will help identifying retinitis much more simpler than what we think it is. Thank you.
So thanks, Mudit.